In this video, I'm going to discuss the myocardial infarction. Myocardial infarction is also known as the heart attack. What is meant by heart attack? It is nothing but myocardial infarction. In heart attack, what happens? There is death of cardiac muscle tissue or cardiac myocyte death. As you can see in this illustration, there is cardiac myocyte death. This is called myocardial infarction. This cardiac myocyte death or myocardial infarction is due to prolonged severe ischemia. Ischemia is nothing but what? Decreased or diminished blood supply, or there is no blood supply to heart or cardiac myocytes. That leads to death of cardiac myocytes. Now let's discuss the pathogenesis of myocardial infarction. One of the causes of myocardial infarction is coronary artery occlusion. There is pre-existing atheromatous plaque in the coronary artery, one of the coronary arteries. That atheromatous plaque undergo acute change. As you can see in this coronary artery, there is pre-existing atheromatous plaque that will undergo acute change. This acute change consists of, what are the changes? 1. Intraplaque hemorrhage. The atheromatous plaque is supplied by the vasa vasorum of coronary artery. That vasa vasorum undergo hemorrhage. And second one is rupture of atheromatous plaque. Third one is ulceration of atheromatous plaque. These are the acute changes. 3, okay? These 3 are acute changes that happens in atheromatous plaque that is present in coronary artery. How coronary artery occlusion actually occurs after atheromatous plaque change? How actually occlusion occurs after acute change? See, vasospasm and thrombus formation occurs due to acute change. How? Consider there is rupture of atheromatous plaque. There is subendothelial collagen exposure, and this leads to platelet adhesion. Platelet adhesion leads to platelet activation. This platelet activation leads to release of contents of platelet granules. Okay, and another consequence of platelet activation is platelet aggregation. These are the 2 results of platelet activation. So the final result, final outcome of this process is 1. Vasospasm due to contents of platelet granules that are released. This leads to decreased lumen size of coronary artery. And another one is thrombus formation by platelet aggregation. That leads to occlusion. Now, the second cause other than coronary artery occlusion is vasospasm may occur due to some drugs. One is cocaine and ephedrine. And third cause of myocardial infarction is emboli formation. In cases like left atrial fibrillations, and in case like vegetations of infective endocarditis. Left atrial fibrillation and vegetations of infective endocarditis. And third one is intracardiac prosthetic material. This intracardiac prosthetic material creates turbulence in blood flow that leads to emboli formation. Now let's discuss how actually emboli is formed in atrial fibrillation. Consider left atrial fibrillation. This atrial fibrillation leads to turbulent blood flow in left atrium. That leads to emboli formation. Blood from left atrium goes to left ventricle. So from left ventricle, it is pumped to heart through coronary artery. While going in coronary artery, the emboli blocks coronary artery. That leads to decreased blood supply to heart. And these vegetations on the heart valve in infective endocarditis may dislodge and enter into circulation, and they may block the coronary artery. So see, this is the vegetations in the infective endocarditis that may dislodge and block coronary artery. The fourth cause of MI, myocardial infarction, is ischemia of heart. Other than coronary artery atherosclerosis, without any coronary artery atherosclerosis, there may be ischemia of heart. How? What are these cause? Let me discuss. One is small intramural coronary artery vessel vasculitis. Intramural means the wall, muscle wall of heart. There are small vessels inside those heart that arise from main coronary arteries. They may undergo vasculitis. Or this in sickle cell disease also, these sickle cells may undergo and lodge in the small vessels, intramural vessels, and cause occlusion. And there may be amyloid deposition in those vessels. Or maybe shock, that is systemic BP decreases. All these above causes leads to multiple microinfarction because the area supplied by these small intramural coronary arteries are small. So there are multiple small infarctions. Now, what is the response of myocardial tissue to ischemia? So there is ischemia. Ischemia leads to decreased blood supply and decreased oxygen supply. What are the response? Two response. One is rapid myocardial dysfunction, and another response if ischemia is prolonged.
These are
that
the two
leads
responses. Myocardial dysfunction
cardiac
is nothing but heart
myocyte
failure.
death.
Heart failure is nothing but failure to pump blood. So now, myocardial dysfunction. There is decreased oxygen supply due to ischemia. This leads to decreased contractility. Decreased contractility occurs within 2 minutes of onset of ischemia. This leads to decreased oxygen supply, leads to decreased aerobic metabolism. That leads to ATP depletion plus accumulation of noxious metabolites like lactic acid. In addition to ATP depletion, there is accumulation of noxious metabolites. ATP depletion. The ATP depletion starts within seconds of onset of ischemia, and ATP is reduced to 50% of its normal value within 10 minutes of onset of ischemia, and it is reduced to 10% of normal value within 30 minutes of onset of ischemia. So all these events that occur within the 30 minutes of ischemia are potentially reversible by reperfusion therapy. Reperfusion is by putting stent and coronary bypass surgery. If ischemia lasts longer, like more than 30 minutes, what happens? There is irreversible injury to cells of heart. That is myocyte death can happen, and that may undergo necrosis also. If there is increase in ischemia, that is prolonged more than 30 minutes, that leads to myocyte death. This myocyte death leads to dysfunction of cell membrane of myocyte. That leads to leakage of contents of myocyte. These contents are myoglobin, troponin, and LDH and creatine kinase. Their level increases in blood circulation. This is the basis for biochemical test or blood test in MI. If ischemia lasts longer than 1 hour, that leads to microvascular injury. Let's summarize this. Loss of contractility starts within 2 minutes of onset of ischemia. ATP depletion. The onset ATP starts depleting within seconds, and it is reduced to 50% of its normal value within 10 minutes, and it is reduced to 10% of its normal value at the end of 30 minutes. If ischemia is more than 30 minutes, that leads to irreversible injury of myocytes and cardiac myocyte death. If it is more than 1 hour, that leads to microvascular injury. All the events that occur within 30 minutes are potentially reversible by reperfusion therapy. Now, patterns of infarction, myocardial infarction. Before the actual patterns of infarction, let's discuss patterns of myocardial perfusion. The myocardial blood supply is from epicardium to endocardium because the coronary arteries are situated outside the heart, right? Actual bulk of heart. So the blood goes from epicardium to endocardium. So because of this, endocardium is susceptible to ischemia because it receives relatively less blood than compared to epicardium. but there is a sparing of thin rim of endocardium. This is due to direct oxygen diffusion from the blood in the ventricle chamber. So this is the zone of necrosis that starts from endocardium to epicardium. See, the perfusion is from epicardium to endocardium direction. The spread of necrosis or death is direction is from endocardium to epicardium, quite opposite. So now let's discuss the actual pattern of myocardial infarction. Patterns of myocardial infarction. One is transmural infarction. This is due to complete occlusion of coronary arteries, one of the coronary arteries. Complete occlusion. The word complete occlusion is important. This leads to whole muscle wall thickness involvement. That is, whole muscle wall of heart is involved in the infarction. That leads to ST segment elevated myocardial infarction. Second one is subendocardial infarction. This is due to partial or transient occlusion in one of the coronary arteries. That leads to non-ST segment elevated MI, myocardial infarction. Third one is multifocal microinfarction. This is due to vasculitis or abnormalities in the small intramural blood vessels that supply heart wall.